Well, hello, this is Dr. Philip May, and today we'll be talking about using bisphosphonates to reduce the risk for fracture in persons with medically complex developmental disability. What do we mean by developmental disabilities? Developmental disabilities refer to various congenital conditions such as intellectual disability, epilepsy, cerebral palsy, and autism. A medically complex developmental disability refers to a developmental disability that is associated with multiple chronic health conditions. For example, osteoporosis, fractures, GERD, seizures, motor dysfunction, maladaptive behaviors, and pneumonia. Adults with developmental disabilities who reside in state-operated facilities would often be considered medically complex. As mentioned in the previous slide, fractures are prevalent in persons with medically complex developmental disability. The increased fracture rate is related to three conditions: an unsafe environment, risk for falling, and poor bone quality and bone strength. The rest of this talk, we're going to be focusing on poor bone quality and strength. Poor bone quality and strength is related to three interrelated, measurable, and correctable fracture risk factors. One, low bone mineral density, which is determined by DXA analysis. And the second is increased metabolic bone turnover, and there are various serum markers of bone turnover that one can order, but P1NP and CTX are popular now. And thirdly, suboptimal serum levels of 25-hydroxyvitamin D. These three factors can contribute to loss of bone strength. Next, we're going to be focusing on metabolic bone turnover. Bone turnover refers to the balance between production and destruction of bone, or formation and resorption of bone. Normally, formation and resorption are balanced. In this particular slide, the big arrow going down indicates that there's more resorption going on than there is formation, but eventually the formation will catch up with the resorption as the osteoblasts begin to fill in the pits made by the osteoclasts with new bone. So they end up balancing. So you have so-called coupled or balanced bone turnover. Now there are three cells that produce and control bone remodeling in the skeleton. And bone remodeling cycle begins with osteoclastic bone resorption, which occurs over about 10 days. And this is followed by osteoblastic bone formation, which takes much longer. Whereas once those pits are made by the osteoclasts, it takes about 3 months for the repair to occur. The biochemical markers of bone turnover reflect the activity of the osteoclast and osteoblast. But also, there is a third cell, the osteocyte, which is actually derived from osteoblasts that become trapped in the bone after they produce osteoid that becomes mineralized. And the osteocytes produce sclerostin and RANKL, which we'll be talking about in subsequent slides. The osteoblast makes RANKL. RANKL, as we will be discussing, promotes conversion of macrophages to osteoclasts. Now, what are the causes of low bone mineral density? Again, when we refer to bone mineral density, we're talking about the DXA analysis. The major causes, in a general sense, are either increased bone resorption or decreased bone formation, or a combination of increased bone resorption or decreased bone formation. And as mentioned before, that RANKL ligand is essential for osteoclast formation, and the RANKL ligand can come from either an osteoblast or an osteocyte, and it is blocked by, RANKL ligand is blocked by OPG, or osteoprotegerin, and the drug Prolia acts like OPG and blocks RANKL ligand. If RANKL ligand, which normally would interact with the RANK receptor on a macrophage, if that is blocked, then the osteoclasts won't form. So keep that in mind. Now, focusing on the osteoclast, you can see from this slide that the major functions of the osteoclast is the demineralization of bone, and it does this through the production and secretion of proteolytic enzymes and hydrochloric acid. The hydrochloric acid dissolves the hydroxyapatite mineral and releases calcium into the bloodstream, whereas the proteolytic enzymes, for example, Cathepsin K, breaks up the proteins and that make up the matrix of bone. So actually a pit is created a pit in the bone is created by the osteoclast, which later is filled in by the osteoblast when they come in to do their repair. Now, the osteocyte has long dendritic processes that interact with both the osteoblast and the osteoclast. Now, the major stimulation for the osteocyte is reduced mechanical loading. In other words, if you, with reduced physical activity or paralysis, and the person's weight-bearing activity decreases, this stimulates the osteocyte to produce sclerostin and RANKL ligand, and the sclerostin will inhibit the formation of osteoblasts, and the RANKL ligand will stimulate the formation of osteoclasts. So you have a situation where when the osteocyte gets stimulated, not only is bone broken down, the new bone is not being formed. So there's a rapid breakdown of bone, and this can lead to increased bone fragility. And here's another figure which represents the activity of the osteocytes. You can see that the osteocytes with the long dendritic processes interact with both the osteoclast and the osteoblast. The RANKL ligand will stimulate the formation of the osteoclast, and the sclerostin will inhibit the formation of the osteoblast. Now, the main message here is that RANKL ligand is produced by the osteoblast and the osteocytes, and that means that more osteoclast and more destruction of bone will occur, whereas sclerostin, which is produced by the osteocytes, means fewer osteoblasts and less bone is being made. And here's a summary of the overall overview of the physiology. And just to take you through this quickly, if you look at the red rectangles, especially the one on the left, it says decrease of serum calcium, and the one on the far right says increase of serum calcium. This is all about maintaining a normal serum level of calcium. And the osteoclast formation and activation in the yellow box there will lead to increased serum calcium levels, which will then feed back and inhibit parathyroid hormone. So I would suggest that you pause the slides here and study this a little bit. You have to think about it. But it's all about keeping a normal level of calcium. And one of the dangers of inhibiting osteoclasts is that this protective mechanism of maintaining normal serum calcium levels is inhibited. So you depend on dietary calcium and a good vitamin D level because the osteoclasts are being inhibited. Okay, let's move on to talk about bisphosphonates, the chemistry, physiology, and clinical application. Bisphosphonates have the PCP structure, and they are analogous to the pyrophosphate, which they block, and they have radical side chains which contain nitrogen or not, which we'll get into. Now, bisphosphonates bind to bone, and then the osteoclast ingests them after they attach to the bone, and this then leads to apoptosis of the osteoclast by interfering with the HMG-CoA pathway, which is the same HMG-CoA that is blocked by statins designed to lower cholesterol levels. So you can see in this pathway that the bisphosphonates block the farnesyl pyrophosphate synthetase, and this leads to a failure to produce an adequate cell membrane in the osteoclast. When this pathway is blocked in the osteoclast, it leads to the death of the cell, and this is how bisphosphonates reduce the activity of the osteoclasts. And here's some example of some bisphosphonates. You can see that the R2 side chain of the newer ones contain nitrogen, and this makes them much more potent than the older ones like didronel, which do not have nitrogen in the R2 side chain. Now, bisphosphonates have a lot of side effects and potential toxicity. I want to point out hypocalcemia, an increased parathyroid hormone, can occur, and probably this happens to a mild degree. It's not always clinically significant, obviously, but it should be taken into account that when you block the osteoclast with bisphosphonates, that the calcium that would normally be supplied by this activity is reduced, and you become very dependent on vitamin D and calcium. So it would be ideal to keep that parathyroid hormone suppressed, and it would be suppressed if you corrected the hypocalcemia. So this is one of the take-home messages is it's very important to maintain an adequate level of vitamin D so that the secondary hyperparathyroidism doesn't occur. Now, determination of the efficacy of treatment, which is intended to improve bone strength and reduce the fracture, it can be determined in a number of ways. First, you can determine the fracture incidence, and if you have a practice which has a certain number of patients, it'll take you many years to show in your practice that your fracture rate has gone down. If you were involved with a big clinical trial and you have hundreds or thousands of patients, then of course you could find out sooner than 12 years, but it's going to take a long time to find out whether the bisphosphonate is working if you're using fracture incidence as your measure of efficacy. Now, bone mineral density, you can see a change in bone mineral density in 12 months. 1 or 2 years, you can see bone mineral density increase, And while that's not as elegant as showing a reduced incidence of fractures, nonetheless, if your bone mineral density is improved, then your risk for fracture is down. But even better, the bone turnover markers will improve within a few months, 2 or 3, 4 months. The bone turnover markers can, if you're using bisphosphonates, you look for the CTX suppression, and that, if that occurs, then that means that there's less osteoclastic activity, less calcium being taken out of bone, and therefore the bones become stronger. And here's the comparison of clinical trials using bisphosphonates to reduce the risk for fracture. And you can see with these large studies that using either Fosamax, Actonel, or intravenous reclast, that bisphosphonates are effective. The core registration studies show over a period of up to 3 or 4 years, they're definitely effective. It's a little bit questionable whether a significant effect, improvement, past that, although they seem to maintain their efficacy. It doesn't necessarily get any better, and this has led to a question of whether a drug holiday should occur because of the occurrence of atypical fractures and osteonecrosis of the jaw. But that, we're not going to get into that with this talk. But the issue of drug holidays is an important area to discuss in the future. And we can also use bone mineral density and bone turnover markers to evaluate the risk for fracture. And in this slide, this shows that having a combination of a high bone marker like CTX plus a low bone mineral density shows the greatest risk for fracture. So this is another way to demonstrate the efficacy of treatment. And here's an actual example, a study of a series of 31 patients who were on bisphosphonates, and it showed that the CTX came down with bisphosphonate treatment, and the P1NP will eventually come down as well, although it's not as to the same degree. But as the pits are filled in and there's less need for the parathyroid hormone to stimulate the osteoblasts and produce osteoid, that the actual production will come down as well. And this is just for a point of comparison, that when you use Teriparatide, that this correlates, that efficacy correlates very well with bone markers. And this is just another example of that. And vitamin D is essential here. That Carmel showed in 2012 that when the serum 25-hydroxy vitamin D level was greater than 40 nanograms per ml, that the success rate with bisphosphonates was much better. And this is just an overview of the bone physiology, and to point out the danger of suppression of osteoclastic activity. It makes you dependent on, if you're going to use the bisphosphonate to suppress the osteoclast, that you really need to be sure that you have adequate calcium and vitamin D, because the osteoclast is going to be inhibited and not be available to you to correct a serum calcium level should it become too low. The bottom line, the bisphosphonates can be very effective in reducing the risk for fracture, but failure rate can be significant. It may take 1 to 2 years to demonstrate efficacy of treatment by showing stability or improvement of bone mineral density by DXA analysis. Efficacy can be demonstrated in 3 or 4 months by showing reduced bone turnover. Maintaining a serum 25-hydroxy-vitamin D level of greater than 40 nanograms per ml improves the efficacy of bisphosphonates. Weight-bearing physical activity should be maintained if at all possible to suppress sclerostin, which is released by osteocytes in response to loss of weight-bearing physical activity. Thank you very much for listening. If you have any questions, please send me an email to ifcd.pmay@gmail.com. I'd be happy to send you a PDF file of the slides or answer any questions that you might have. Bye-bye.